Well, thank you everybody for, I guess, looking in at all the remote sites, and thank you all for coming. I consider this a real honor to be able to speak to an audience of critical care people. And my goals I'll talk about in a second, but I think it was an important exercise for me to sort of look into what's out there in the literature about critical care skills in palliative medicine and sort of integrated models and how we can bring palliative medicine into a more naturally functioning process in our work. So that's really what I hope to talk more about. There are no financial disclosures. CME is all yours. So the objectives are to identify individual and system-related challenges to goal setting with patients and families in the ICU, recognize primary palliative care communication skills for critical care providers and indications for specialty consultation, apply a stepwise approach to establishing goals for critical interventions that reflect the values of the patient. So that's going to be a recurring theme about we talk about. Patient values is a structured process. And consider some implementation strategies that you might want to consider in your own environment, wherever you may be, that consistently communicate patient-driven goals for immediate and ongoing critical interventions. So I'll use a case example for the idea of a sprint versus a marathon. This is the title of my talk. So the first case is the sprint. 50-year-old man with AIDS, HCV, many times that's there too, hepatic cirrhosis and severe coagulopathy, recurrent variceal bleeding, day 6 in a ventilator on ICU, now in DIC active bleeding, utilizing high volumes of blood products, on escalating pressors, high vent settings, and on CRT. Now, this sounds like a familiar type of case that you've all seen. And the point here is that there are a lot of rapid decisions that need to be made. So this has got a certain flavor to it. I want you to contrast that with another case, although still very serious, but there's many other uncertainties in this case. So this is more the marathon. A 27-year-old woman who fell from a window at approximately 30 feet onto pavement, large contra coup intracranial hemorrhage. GCS on arrival was 3, but in the first 48 hours, she improved to about a 5. Day 4, rapidly declined with unilateral dilated pupil, went to craniectomy. Following craniectomy, patient had a PA arrest in the PACU with Roski within 3 minutes, so relatively brief. By day 6, so also day 6, patient has evidence of early ARDS, is requiring norepi, but at a low level, and she's on CRT. So this case, from a prognostic perspective, still has many questions. Like, what might this mean neurologically? What might be a recoverable scenario? There's a lot to talk about in this case. It's different, although still life-threatening. So I want you to conceptually think about the idea that we are making rapid decisions all the time, but in some cases, and sometimes it's more just a combination of the two, it's kind of the slow and steady process of information transfer, talking about understanding this person, and then putting it into the context of the medical reality. And that's more of a process that can take time. So there are many challenges, as you all know. You've all worked with families and multiple different services. Many people have different ideas about what might be going on with the patient. Communication is not always controlled, and some of it's disparate between providers. So there's a lot of things that can come up. Now, what I want to point out here is that these challenges can be influenced by the healthcare provider. The healthcare provider can either exacerbate or improve some of the challenges that come from either the patient or family or from the system itself. And the things that I'm pointing out here are things that you know, we can control to some degree, and to some degree we cannot. This review looked at a construct, and this was a while ago, but it's, I think, a good way to kind of think about what happens with these conflicts that we're always seeing in the ICU. Why do we see conflicts? What are the communication things that keep coming up with patients and families. And I want you to focus primarily on the physician APP column, because these are things that we definitely have control over, but we may not realize we may be consciously or unconsciously influencing the dynamic with the family or with other providers. Specific things are when there's prognostic uncertainty, you may communicate a certain idea, but a different provider may be communicating it in a different way. Families hearing different pieces of it, so they're experiencing different aspects of hope or expectation. The perceptions of death in the ICU is a normal thing, but it also can be perceived by the providers as well as, you know, the nurses, all the people that are working with these patients, as kind of a failure of this aggressive attempt to try to prevent death from happening. And yet it's still a very prominent part of the work that we do. So how do we integrate these processes without unnecessarily sort of influencing a negative context to an inevitable situation in the family? Quality of life beliefs. This can go in either direction. And if the perception of the physician or APP is that this is no quality of life, and that's communicated before it's understood what the quality of life expectations of the family and patient might be, it can really throw up a wall to say, who do you think you are? Like, how can you tell us what's an acceptable life? Those are things that we do in an unconscious way. Of course we have opinions about these things, and it may be we would not want that, or we couldn't imagine maybe that kind of life. But it's all context, and they may not be seeing all that detail, and it's hard for them to sort of jump through that quickly. So knowledge and skill, and specifically with communication skills. It's very difficult when you're talking about communication skills, which is an essential part of what we do in any critical care case. Communication is essential. It's an everyday event, and how that communication occurs has high risk. And so sometimes these communications get kind of screwed up. People may believe that their communication style is perfectly fine, and it may have nothing to do with what's actually happening and how they're being received by the patient and family. That's a very different skill set to be able to understand how did they experience what you just communicated. So I just want you to think about that. So here's another study that I thought was interesting in terms of how information can be so off. And we often want to start with are we talking the same language? Do we really even, do you hear what I'm saying, kind of thing. This one looked at, it was a fairly large study that looked at patient family perception of CPR survival to discharge. And they were looking at patients and families in the ICU. Their perception was that in a cardiac arrest in an ICU, 72% of the time they would survive to discharge. Now we all know that that's way off in terms of survival data, but that piece of information is actually very close to a couple of other studies that looked at out-of-hospital cardiac arrest and asked people to estimate what the likelihood of survival in an out-of-hospital cardiac arrest might be, and it's around 75%. So people have these perceptions based on a variety of cultural things, a variety of expectations for what medicine can do under those circumstances. It's informed by the media. They see things on television that make no sense to us, but they still see them, and they incorporate them into a narrative that seems more real. So what was interesting to me in this one, though, is that they actually presented then the information that we know, which is it's only about 18% for patients who are in the hospital, 16% for patients in the ICUs. But in fact, only just by giving them the data, it wasn't enough to change their mind. Only a few of them changed their mind from what they had committed to, that they believed that this would be the outcome. Same thing, little more of an influence when they talked about good brain function, survival to discharge, which is only about 14%. A few more changed their mind. So it's not just the data. The data and the information, we sometimes in palliative care refer to this as the download of information, which may not be what it is that helps people to come to the same point. So their goals, their understanding, their values are a critical piece of this. You know, these are huge differences in terms of where we want them to be and where they actually are. Okay. So primary palliative care skills in the ICU. By that I mean the skills that everyone working in the ICU should have for communication in their patients as it relates to palliative concerns. And palliative meaning, you know, anything about assuring the comfort of the patient, assuring the patient's perspective, understanding the patient's values, recognizing the patient as a person, so that you can use that information to then put into context the medical truth that you know, and hopefully come together in a way that you're basically steering the same ship and you're not on different planets. Secondary palliative care skills might be specialty consultation, in other words. Okay. So here's another study. This looked at a number of patients who were in the hospital. Didn't matter whether they're in ICU or a regular inpatient ward. They were elderly patients over the age of 80, and they followed them for 6 months or until death, and they communicated both with the patient at the time of the admission as well as the families after the person died to get some of the data. What was interesting is that they used there was the control group, and then there was a randomly assigned intervention group where it was just a simple training process for facilitators in advanced care planning, so that they would talk to them in a certain way about certain details about their care. So in the group of the intervention, surrogate assignment, and these were things that they focused on. So surrogate assignment, end-of-life wishes known, and involvement in end-of-life decision-making were part of the intervention. Okay? So maybe not surprising, but the data in this is showing a huge difference in doing something that's a little bit more controlled and driven by the patient's perspective and their goals. Surrogate being assigned, which is a critical issue for anybody who may progress to a dying process and become, you know, unable to communicate their wishes or what's acceptable or unacceptable to them. 3 times surrogate assignment in cases where there was an intervention. The patient's end-of-life wishes known and respected at death, 86% in the intervention group actually had that occur, only 30% in the control group. Involvement in end-of-life decision-making, as it was perceived, was about 3/4 in the intervention group and about half in the control group. And this was, I think, for me, one of the more important points, which was after the patients who did die, they talked to the families to see how it kind of went. They felt that the satisfaction in the way that this person died was on their terms, basically. 86% felt very much so. Whereas in the control group, it was only 37%. And so I think this speaks to an idea that it's a really simple intervention. It was more just giving providers a little bit of skills to be able to say, these are the things I need to talk about. These are the things that are going to be important. Let's make sure this is, you know, covered. It's that kind of thing. Doesn't have to be, you know, highly specialized dialogue, very time-consuming. It just has to be sort of a few points that need to be made. Now, this is from the Critical Care Innovations Group out of UCSF, and I think, you know, it's a good structure to just kind of think about in terms of what are we trying to do. So their recommendations for ICU communications are engage the patients and families early in advanced care planning. Identify a surrogate decision maker. How many times have you come onto a case where you thought the surrogate decision maker was somebody, and then you find out a week later that there's somebody else who's the legal surrogate? You know, I mean, and these are things that could be figured out quickly, but you have to ask the right questions. You need to target the right people. You need to use your team and, you know, get the social worker on it and say, you know, I think this is the legal surrogate, but could you verify that? Provide opportunities for patients and families to participate in rounds and handoffs, which I think some ICUs, they do that, but not all of them, and this is a pretty universal recommendation. We'll go through a few of the others from some other recommendations as well. And of course, make the most out of family meetings, meaning intentional, purposeful, recognizing why you're in the room, what you're hoping hoping to get out of this accepting what you get, whether it's what you wanted or not. That's making the most out of it. That gives you the opportunity to keep going. So some of the external recommendations, which are what I would sort of also place in the sprint category, is AAHQ came out with recommendations for first day in the ICU. What they included was advanced directive completion and code status being established. I would modify that personally, because I feel like trying to get an advanced directive done in day one of an ICU is going to be really difficult, because you're talking about the majority of patients are in critical condition, many of which are delirious. An advanced directive comes from the person. And so you don't do an advanced directive with a surrogate. You can talk about advanced care planning and try to get a sense of what's important to that person. So I might modify this as maybe you begin advanced care planning. I think that's an unreasonable expectation, is what I'm saying. Maybe look for the advanced directive. Find one if there is one. That's a better recommendation. So this is a sort of a look at what might be reasonable guidelines for focusing on a patient-centered approach to communications in the ICU. And this is back in 10 years. They came up with these 9 recommendations, but of course on the top is shared decision-making. And you see at the bottom, the 9th one is primary and secondary palliative care involvement. All the rest of it, I think, makes perfect sense. You know, we all try to do these things. You mitigate stress, you intervene, provide cultural support, spiritual support whenever possible. One of the things that I think is a particular challenge, and I'm not sure, you know, people are watching on what the experience is in your environments, but at Grady, patient visitation is its own issue. And when you're dealing with families that are getting very frustrated about, you know, how visitation is sort of managed, there's really rigid rules about whether they come in or whether they don't come in. But there's opportunity, of course, to adapt depending on the situation. And there's really not good structures, at least in our place right now. We're beginning to look at that, though, as a way to sort of support the family. But all of these things, I think, are very relevant. So last year, in sort of expanding on some of those ideas, the American College of Critical Care Medicine and the American Thoracic Society decided to come up with a policy statement to support what they think are best practices in communication in the ICU, and I think those are great. So they started with the definition of shared decision-making, I think, just to make sure everybody understood what they were talking about. So shared decision-making being a collaborative process allowing patients or their surrogates and clinicians to make healthcare decisions together, taking into account the best scientific evidence available, as well as the patient's values, goals, and preferences. So it's this dynamic of those two sort of entities. It's information that's as true and clear as can be possible, and the patient's values and structures, so you can try to merge them and work together. Clinicians should engage in that process to define the goals. So you can't really make goals if there's not consistent information, first of all. You can't make goals if you have no idea what the values of the patient or the family might be. You can't direct them, in other words, in the medical truth that you understand, unless you have some context to put it in. So clinicians, of course, should use as their default approach for a shared decision-making process these 3 elements, which I think should always be on our mind. And they kind of function in a sequential manner. So information exchange, then deliberation about, you know, information and values and goals, and then making a decision, a collaborative decision. So you hear their values and goals, you have this information that you think they need to understand, and then you make decisions together that are medically reasonable, not medically unreasonable. Like, we get worried that, you know, we're asking the family what do they want. We never really should be doing that. We should be guiding them in what's possible, not what they want. Like, people don't want people to die. People don't want people to not function. People don't want people to be in an ICU. People don't want people to be in a nursing home. You know, but we can't control what that is. We can control certain pieces of it that are the medical reality. So we help to work with them within the context of what's important and try to merge the medical reality to their values the best we can. three more that they came up with were clinicians should tailor, and I think this is an interesting sort of shift. So this was published last year, but I agree with that. Clinicians should tailor the decision-making process. So it's based on the preferences of the patient or surrogate. It's either going to be primarily patient-directed, surrogate-directed, or clinician-directed. And by saying that, there are times where we've all been through this, where you, in talking to the family or the primary surrogate, their idea is they don't feel like they want to be burdened with making the decision that's going to be a life or death decision, right? So they make it to the point, this happens in pediatrics all the time, by the way. They make it to the point where they have to say, I can't make that kind of a decision. And that, for us, is a cue that they're asking to be unburdened from that decision. So sometimes it means you need to ask more questions about, would you like me to make these decisions with all of the things that we've been talking about in mind? Because I can do that, and I can guide this. I don't want to burden you with that piece of this. You don't have to. In fact, that decision-making process is much more prevalent in sort of the UK systems, Canada, UK, Australia, New Zealand. They're all functioning in a different system, which we view as more paternalistic, and it is. However, they don't ask the questions in the same way that we do regarding CPR. They just don't. There's people that are candidates for resuscitation, and there are people who are not candidates for resuscitation. And it's really viewed that way. So I think there's sort of a pendulum swing that we have to pay attention to here, which is you're not ever really asking the family or even the patient what they kind of want. You're asking what you need to understand about what's an acceptable outcome, regardless of what you can offer them. Then you talk about what's possible. That may or may not include doing CPR at the end of their life. And you would guide them more in that direction, hopefully. Fifth recommendation was clinicians should be trained specifically in communication skills. And I'll give you some recommendations for some of these processes that are out there, some of these programs that I think are excellent. And research is needed to evaluate some of these decision-making strategies. It's still very unclear how people make these decisions. You saw in that early study that I mentioned that it's a big sort of black box to us. Why does this person make that decision? That person makes that. It's the same case. Their conclusion then is more about this sort of looking for what is needed in this particular situation. Is it more the clinician needing to guide more? Is it more that the family needs to have more autonomy? You know, and you have to guide your, it's a bit of a nuance, but you have to understand that in order to be effective. This is getting into sort of more of the sort of longer term processes. So this study looked at, it took groups of physicians, nurses, patients, family members, and they did it in, I think, 6 different institutions. It was all in the Mid-Atlantic, but it was a good construct. They were taking some of the recommendations from the prior policy that I brought up, and they decided they wanted to look at what are reliable sort of non-emergent interventions that we do in the ICU, where we should be thinking about goals before we even offer the thing. So that's kind of the idea. So they used this question to ask, and they used this sort of triple node Delphi model to hone it down to the most reliable, and it came up with 8. And it's these 8 things, which we do all the time, of course. But it's do not offer a blank unless it will help achieve the patient's treatment goal. And so permanent feeding tube, tracheostomy, permanent dialysis catheter. What I thought was interesting about this is there was high levels of concordance across both the medical people as well as the non-medical people on these, because they were feeling like understanding what the implications of these interventions were was meaningful. And if you didn't feel like this was something that you could accept or that your loved one could live with, then you wouldn't want it to be offered as something that was just available, right? So think about the patients in, say, the neuro ICU that, you know, the outcome is almost certain that they're going to be, say, in a dependent condition in either a nursing home or family constantly caring for them. That may be an unacceptable outcome to some patients. So if that's an unacceptable outcome, the offering of a feeding tube or a tracheostomy or being on and off of a ventilator would be completely inconsistent with their values or goals. So the question then becomes, you know, how are you supporting them by sort of saying, well, we could do this or we could do that? Or are you helping to understand what it is that's acceptable to them? And then saying, you know, under these circumstances, with that information, these are the things that I would recommend. That's a very different approach. So, here's another study that looked at using, this is another sort of structured advanced care planning effort to get at the values of the patient and the surrogate. They used this mnemonic basically to help structure the intervention group to say, you're going to use this when you're talking to these patients. And these are ICU patients. So what they found was that the family conferences tended to be a little bit longer. So that was, you know, none of us want to spend more time doing family meetings, et cetera. There's a lot to do, but they did see that the family was speaking more in these meetings because they were using this structure. So it was more about the family, not more about the providers just giving information. The more important outcome of using this approach was that the families, in a follow-up at 90 days, they found substantially lower levels of PTSD, anxiety, and depression using standardized scales that were appropriate. And so this was a good study that looked at a simple intervention that guided how do you communicate to these families, and it limited bad outcomes for the families, which we're learning more and more about. The families of ICU patients sometimes don't do well. Patients themselves don't do well as well. So in trying to get at goals, there's both a sort of personal skills that we have to develop, but there's also system-related skills that we have to develop in a more cohesive way, so that we're all kind of agreeing that this is the method that's going to get it. It's not one thing, in other words. This was just published by the Annals of the American Thoracic Society, and I think it's excellent, and I think you should all read it. And it's a good reference if you want to try to use this as a structure to try to implement some ideas in the ICU. I think it's excellent. What they pointed out is that there are 5 goals for clinician and family communications. And this is based on a very good review of the literature and trying to understand what it is that we're trying to accomplish, because we have a lot to do. There's a lot of physiological things we have to attend to, but we also have to communicate, and we need to do it in a way that's going to mean something. So these 5 things should be your goals. All right, establishing trust, you know, which has been associated with better outcomes when the family is trusted. Providing emotional support, and in this way, emotional support is distinct from cognitive information. And you have to be able to separate them, because we know very well, and this has been well studied, is that if a family or a patient is in a highly emotional state, you cannot give them cognitive information. They're just not going to hear it. You may think you told them something, but they may remember a piece of it. They may have no idea what you said. So you have to recognize an emotional state that's non-receptive. And if you're having an emotional sort of exchange because you're giving them really bad information, it may have to be done in a piecemeal manner. Like, you give them a little bit of information, make sure you're attending to their emotional response to that, and then trying to figure out whether you can proceed or not. And if you can, then you ask permission and you go to the next chunk of bad information so that they can process it incrementally. And if it's getting too much, and you ask, and they say, I can't hear this anymore, you know, you come back later, maybe you come back hours, maybe you come back in the morning. But, you know, and it's always a dynamic. I mean, sometimes you have to, it's urgent information, you have to let them know. But you do have to be sensitive to a download of bad data means nothing. Like, you didn't do anything. You wasted time, basically. So, you know, that's not efficient communication. Making sure that the family understands. So 2 and 3 are attending to emotions and attending to cognitive information, and making sure it's consistent and clear among providers. You know, we all hate when there's like the ICU tells the family one thing, and then say, I don't know, the nephrologist comes in and says something completely different related to something you already talked about. And it's because it's a perceptual thing, but they're just not communicating in a cohesive way. So the family now is like, I don't know what's going on. And we want to try to avoid that, of course. Understanding of the patient as a person before they ended up in the ICU, because that context helps you to understand what you're aiming for. So we think about what was their baseline status, but we also want to try to understand what kind of a person was this, what the value was. You know, because we're going to be now talking about somebody who might be very different at the other end of this if they survive. So understanding what, you know, that target was for them. You know, and there's a variety of things you hear when people describe, you know, when you can ask even an open-ended question like, what kind of a person were they? They'll say things like, you know, freewheeling, fun-loving, you know, didn't like to be tied down. Other people, they might say, always concerned about other people, you know, really valued very intense interactions all the time. You know, you hear those things. And that actually can translate into how much is this person going to tolerate, you know, being in a fully dependent condition or being stuck on a ventilator for several months or whatever it is. And certainly the careful deliberation of difficult information or a disparity of intense by the family versus the clinicians. That requires very, very careful dialogue. So this is, I think, a really nice construct of the different things that we do in communication. And it's worth sort of thinking, how do we do this, and are we doing it in a consistent way across providers, in different ICUs? Is it similar? Are we doing enough of these things, right? And there's strengths and weaknesses to each one, so not one of them is the right thing. It's all of them. And it depends on the situation, it depends on what the need is, right? So family-centered rounds, how many of you do family-centered rounds or even know what that is? Okay. So I know we're talking to other people, so I don't want to make it too difficult. So in family-centered rounds, this is engaging the family in the dialogue, right? So what are some of the problems with this is you're engaging the family, it does create certain issues with privacy. You have very limited time because you're in rounds, right? But it helps establish trust and transparency. You're talking about exactly what you need to know with them. They get to ask a few questions as long as it doesn't go in the wrong direction, right? Like if they start talking about big things, you have to cut it off and say, okay, those are really important, and we need to talk about those things, and we're going to come back, and then we'll do that. That's a different process, right? Daily updates, which are great. We need to do that in the ICU. The patients are in flux every day. Daily updates are essential. The good thing about updates is you can do them, you know, at a scheduled time. Like you can say, I'm going to call you at 3 o'clock every day, and we'll review everything. Or you meet in the room. Sometimes the daily updates can be problematic because one specialist says one thing, one specialist says another thing, and now they're confused. Patient portals, which we're trying to use more and more, but there's always stuff. You know, how is it being communicated electronically? When you're communicating in a way that they can't see you or look at you, there's always risk. Hearing your inflections on a phone, better. But when you're typing something, we all know that like how many of us have not written a bad email where the person on the other end had completely misconstrued your intent, right? So there's risk with that whole process, especially when you're dealing with such highly volatile situations that are changing so rapidly and could be very emotional in terms of the implications. So there are problems with it, but it's good because it's convenient, and the asynchronous part of it is either good or bad. You know, like you get to it when you can, but you're dealing with pretty high level concerns here. I think it's good in like family medicine where you can ask a question, they get back to you in a couple of days or whatever. It's fine. So interdisciplinary family meetings have multiple advantages in that it's an opportunity for you to bring everyone together and make sure you have a cohesive message if it's done well. It gives the opportunity for the families to work through and deliberate concerns that are not being attended to in a way that they're satisfied with. So it's helpful. The problem is it's very time consuming, and it also requires getting everyone in the same place at the same time. You know, you talk about herding cats. I mean, trying to get, you know, a neurosurgeon in the same room as the nephrologist, as the oncologist. Like these are you need your own sort of assistant to do those things. It's very difficult. I had to put this on. So this is just thinking about what it might mean to write emails. It says, look at this email from my doctor. I mean, where did he even get that font? Yeah, it's misconstrued. So this is actually from the same article that we've been talking about. And I actually think this is another reason to maybe try to pull it up and review it. I think this is an excellent construct. The people involved in this article also are really great academicians, and I think have done wonderful work in this field. So what this is looking at is more sort of a mock-up of ideas of how might you utilize all of these different approaches, because they're all going to fit in different ways, and they're all going to mean different things to different people. But it's kind of a basic structure that flows. And so I think it's worth looking at and just spending a little time. All right. Now, these three organizations, I would say, are there for more intensive guidance. The Education in Palliative and End-of-Life Care, I don't know if any of you have heard of this, but it's been around for quite a long time. It's out of Northwestern University. And their whole approach is kind of a teach the teacher mechanism. So people go to these EPIC conferences to learn how to sort of do primary palliative care, all right, in whatever it is that you do. I teach in this program as well, and there are social workers, there are chaplains we've had attend, as well as, of course, mostly physicians and nurse practitioners. But it's an opportunity to sort of bring some of these skill sets and learning how to sort of teach it in an effective manner in your own environment. So I actually think it's a great opportunity for the right people. So maybe, you know, and sometimes what they'll do is they'll send sort of a core group of people that want to develop certain structures and skills within their own sort of core. And so they'll send a couple of people to the conference, they'll come back with the whole curriculum, and then start a process of, you know, these are the things we really need to focus on. So it's a great program. Vital Talk is more individual skills development, and it's very intense. It's not cheap either, but it's got exceptional teachers. And so this isn't intended to develop skills and to focus on the things that get you stuck, the things that are making it difficult to sort of work yourself out of, difficult conversations, really bringing you into those moments where you need to come up with some different ideas to pull yourself through it and to maintain productive communication. The last one, IPAL ICU, is improving palliative care in the ICU. It's from the Center to Advance Palliative Care. IPAL ICU has a bunch of material that can help for doing a needs assessment in the ICU, trying to determine what are reasonable triggers in your ICU for, say, palliative care consultation. It's going to be different for every ICU, honestly. So you have to think about what it is that your patient care needs are, what might be working, what's not working with your current palliative care team, what is it you want from them. Those are all things that come up, and this gives you a little more of a structure to do that. Now, I only have a few more minutes, so I just want to give you sort of an overview of some of these principles. The EPIC curriculum uses a 7-step goals of care protocol, and it's basically formatted around the ask, tell, ask idea in communication. How many of you have heard of that as an idea? Okay, well, you don't count. We're taking with us. An ask, tell, ask. This is actually used in not just medical communication. It's a way to communicate with people to make sure that you're being effective. Okay, and it's a very simple idea, and it's probably one of the more important things I want you to take with you from this talk. Is that before telling people things, you need to think, what do I need to ask them? Okay? It's that simple. And then if you can do that, then what you are telling them, you have to modulate by what they're able to hear, then respond to it, ask maybe more questions about what you just told them, and then ask if it's okay to proceed. Then you do it again. And you just keep moving through it. And you can decide, this is productive, this is not productive, we need to stop, keep going. But an ask, tell, ask approach, even in a really basic way, can be very effective. So using that approach, this is, you create the setting, meaning you want to have people where they can sit down, you want to make sure it's the right people that are in the room, you need to make sure you have all the data and the information so that you can answer the questions, that kind of private, quiet, cell phones off, beepers silenced, that's creating the setting. First question is typically asking what they know. A lot of you already know this, and I see you do this, so I know this is part of what you picked up somehow. And then what are they hoping for, which sometimes is not always sort of brought up. But it helps you to understand if there's a disparity. Because if you're way off, you need to then stop and not talk about goals and talk about information. Okay? So goals can only really occur when there's a common shared information. All right, you have to be on the same page. And sometimes that's where you end up. You go into the room thinking you're going to talk about interventions, and you end up only talking about information because they had no idea what was going on. And it's a waste of time to try to start talking about the interventions at that point. Suggesting realistic goals based on their values. All right, so you have to have that before you can suggest the recommendations. You, of course, need to learn the skills of responding empathically, and there's a couple of tools for that. Make a plan that's going to work with collaboration, and then review, revise, and change as needed. In Vital Talk, their approach is a little bit different, but it's similar. So you're starting at a point where it's basically bad news. This isn't what you hoped for, all right? You're basically saying that what has been trucking along is no longer where we're going. So we now have to talk about different goals going forward. So this is a starting point. So you've already had to have communicated information that they've now accepted. Now you can start talking about goals. That's where this starts. You expect emotions and empathize, map the future with them, align with the patient's values, and plan medical treatments that match their values. So it's a relatively simple construct. It's just that when you put yourself in that situation, we've all been there, there's those moments where you get thrown off because you didn't expect it. Either it's an emotional response they're having, or a lack of response, or a lack of comprehension, or something's going on that didn't translate for you in the way you expected. So in reframing, here's just some examples. You give them the information and then saying, given this news, it seems like a good time to talk about what to do now, or we're in a different place. I use we're in a different place a lot because when I can see that they're beginning to recognize that this is different, this is actually just an acknowledgement that it's true. And then we can talk about now what we do, right? The emotions can be simple things like reflecting on what you are witnessing them do, or one of the tools I learned as a fellow was the last 3 words they said or something that might give you a clue on how to respond. Like, I can't believe this is happening. could be followed with, yes, this is unbelievable. You're just connecting with them, all right? And it's that simple, because then they see that you're a trusting resource for them. It's not you're just sort of standing and waiting for the next data piece to give them, right? Trust is a really important part of this, and this is where it happens, is in the empathic responses. And here's actually a construct that is worth knowing about, and all of these are actually available online. I'm going to give you the website. You should just pull it up. You can Google it. If you're going into a difficult family meeting, I would Google Bible Talk and just pull it up and use some of these. Try them out. It shouldn't hurt. I mean, it might actually help. So these are some techniques. So you name what you're seeing. Like, it sounds like you're frustrated. Now, in the parentheses, it's tone it down, because if you're too emphatic about what you're observing, it's aggressive, and it's too aggressive. And so if you're going to say, you seem angry, you're going to, if they are angry, they're going to get worse if you just are that blunt and disconnected from it, right? So you have to kind of gauge how you're going to communicate what you're naming, so that you're naming it in a way that connects you to them and doesn't just separate you. Okay? Understanding, this helps me understand what you're thinking. When they're talking about all the things that they did for this person, this is a good opportunity to say how much it's obvious how much you care for them, how much you love them, and that you've done everything that you could possibly do. You couldn't have avoided this. Those are opportunities to sort of help them in acknowledging them through respect. The other, in supporting, you're going to communicate how you're going to help them the best you can. You're going to do everything that is possible in the circumstances to support, maybe whatever it was that they told you. Like if you end up in a conversation where you may not think this is what you would have chosen, but they say, well, I think it's too soon. We need to, we need more time or something like that. Then you might offer, time in the trial and say, we are going to do absolutely everything to maintain their body's functions. We'll talk again tomorrow. Then you're still on the same page with them. It's not like you're arguing with them or giving them an alternative that is not going to be acceptable to them. And exploring. This can come out when a person completely shuts down and doesn't show any emotion, or they start just tearing up or crying or something. And you might need to just say something, after giving them some silence to respond so that they can allow you to experience it with them. And then just say, can you tell me a little more about what is going on for you right now? What are you thinking about? What are you worried about? Because then you make it something that is very easy to answer. And it may be something that has nothing to do with what's going on and what you just told them. So you wouldn't know unless you said something, right? So mapping the future, given the situation, what's most important for your husband, wife, son, daughter, always use either their name or their relationship, so that they see that you're connecting with them on a personal level. Thinking about it from the perspective of it could be me or a loved one is a good way to start. You never want to do that, though. You never want to say, if it were my mother, because it's not about you, it's about them. And it doesn't matter what your perspective is, frankly, on your values. It's about their values and your information. Like, you still have your own values, but you also have to recognize them and kind of keep them in check. Because it's very easy to sort of inflect what you think they should value. And we have to protect ourselves. We have to sense that in ourselves and be careful. One of the example at the bottom where it gives options is a good way to get around that. Where you just say, well, in this situation, some people might think, that this would be acceptable. Others might say this is acceptable. And still others might say that's acceptable. And these are the things that could happen if we go in this direction or that direction or this direction. you know, and given the things you've told me about your husband, you know, which of these makes more sense to you? Right? Aligning with their values sounds like the most important things are. So you're going in the direction of giving them a recommendation at this point. And then making a plan. So a couple of pearls. Hospice, we get pretty comfortable with saying we're done, okay, clinically. And I get that. When we're thinking about hospice, you need to, and many of you I'm sure think about this, but think of hospice as the H word. You know how people used to say the C word for cancer? Think of hospice as the H word. Don't say it until you've talked about all this other stuff. So this is what's going on, this is what we've talked about, this is what we understand is acceptable, unacceptable. Given what we can do, given what's happening, you know, these are some of the options, these are some of the ways that we can support that, and maybe talk about maintaining symptom control. Like say they say, I just want them to be comfortable. That's sort of commonly where we'll end up. I just want them to be comfortable. But they may have had a really bad experience with hospice or have perceptions that hospice is about, you know, just doping them up until they're dead, which people say. So if you lead with that, you're going to lose them and it's not going to happen. So I would say, you know, let's talk about how do we assure that they remain comfortable. We're not going to be able to prevent them from dying. This is happening. You know, what are some of the ways that we can support them in the best possible way? You know, some of the things are we can do this, we can do that, blah, blah, blah. And sometimes that means involving hospice services so that they can assure that those things are done well. That's a different way of communicating, right? As opposed to, I think it's time for hospice or something like that. Organ donation, another one where it can get a little iffy. And I think we all know that we want to avoid bringing up organ donation personally because it can sometimes derail the opportunity for an organ donation. In a patient's family that might have been more receptive to it if the timing were right, and if the communication about it were done in a certain way. So if you're thinking that the person is going to die and organ donation is on your mind because there may be a good candidate for organ donation, the recommendation is to use only a trained communicator about organ donation, usually from the organ procurement organization. And you can say things like, and this gets a little touchy when you're talking about the ethics of maintaining life-sustaining interventions, but you could say, all right, we're acknowledging that the person is probably going to die, and we want to focus on making sure that they're comfortable. That's reassuring them. There's some other people I'd like to have talk with you to make sure that we've talked about, you know, all of the options, make sure that you understand all of the things that are possible at this point. Because sometimes, if they can make that shift, the organ donation process can really be the difference between something of meaning coming out of an otherwise sort of inconceivable event, you know, like your kid gets in a car accident, you know, we've had these cases, right? So just let them understand, you know, you have to be thinking the person's dying before organ donation is sort of being introduced directly to the family, right? If it's getting close and you're thinking that it could go either way, then, you know, maybe it is time to get the organ procurement people involved. The process of donation after circulatory death determination, which is sort of becoming more and more common, really does require a lot of finesse and communication to make sure that we're going in the right direction. It's much easier, frankly, when you're dealing with brain death. I mean, with brain death, it is what it is. They're declared brain dead. Now, there's only a couple of options, and we're maintaining them on life support for how long? You know, how are we going to make sense out of that? That has its own sort of process. The DCBD cases are much more difficult, and the communication is much more sensitive. So just to be aware of that. So a couple of pearls that I want to leave you with on the communication issues. Real simple stuff. If you're hearing them talking about things that are challenging or worrisome or concerns that they're having, one of the good responses is to say, keep more, and just keep going until they're done. And when they're done, then you can move on to sort of acknowledgement of each of the things that they were saying, and how you're going to sort of deal with all the things that they brought up. This allows them to be heard and to be listened to, and to acknowledge and to demonstrate that you actually are concerned about all these things that they're having. So tell me more gives them permission to give it to you. All right. The ask, tell, ask approach. Hopefully you understand that this is, if you enter a room, the first thing on your mind is, what should I be asking? You've done it. Okay. If that is the one thing you can change, that's great. And I wish. So something bad happened. You don't want it. They don't want it. Acknowledging it. I wish I could give you different information. I wish I had a different answer for you. I wish this didn't turn out this way. All right. So a couple of final points. When to involve secondary palliative care involvement, meaning consultation. It's going to be different for every ICU, but there are some common themes out there. Symptom distress, family distress, poor prognosis for survival. These are all pretty basic, I think. Intensive utilization of healthcare resources, person getting tons and tons of blood products with no end, and we don't understand what we're doing at this point. So in a given institution, looking at the current literature about how palliative care might be useful for an ICU, thinking about what it is that palliative care is helping you with, what it is that you want palliative care to help you with in different ways, and maybe even considering pulling together sort of a core group of, you might call them stakeholders, like the right people that are going to say, okay, this is what we really want to get out of palliative care consultation. Let's talk about how we're going to make that happen. And then work with the palliative care team, because I think, there are differences between how I interface with, say, the neuro ICU versus the SICU versus the MICU. Like, they're all different, and they have different needs for different reasons. So we're thinking about that. So just things to bring up. So in summary, I wanted to just emphasize that the challenges in communication do have certain sort of commonalities to them. We both contribute to some of the problems that create conflict, as well as have the opportunity to intervene in ways that limit those conflicts. These three organizations are tremendous resources to both develop skills within a team. So you could be talking about developing a curriculum for basic functioning skills in palliative care, so that everybody's sort of on the same page and you're all kind of practicing certain things. We do this in emergency medicine all the time. There's actually an EPIC EM for emergency physicians, because there's emergency medicine specific issues that come up in palliative care. Same thing for ICU. They don't have an EPIC ICU though. They have an EPIC for oncology, peds, etc. So Vital Talk, as I said, this is for intensive skills development. So they'll focus on sort of, what you need to work on and helping you to sort of work through it and get better at it. And the IPAL ICU project, which is wonderful and has a tremendous amount of resources for, for thinking about how you can improve some of the functions in your own ICU. So, CME credit. Any questions? I went over a little, sorry. Okay.
A question. I'll upload. I have a question, I guess.
Sure.
In my experience, sometimes by the time we consult palliative care services, so say damage might have been done already during the initial encounter and discussion. What would you recommend, I guess, would be a quick, I know you went over some of the tips and how to maybe approach families and patients, but anything that, because I'm not sure how much training providers get in this, but so if they take away something from today, what would be the best?
So I think some of the keys are when you are concerned about the potential for conflict, palliative care should get involved early. so that we're all working from the same place. If things are trucking along and it's fine, then, you know, it may not be necessary for palliative care to get involved in the case. If things have gone wrong, which they always will, you know, it happens, it then becomes sort of, it's like damage control, service recovery, and the hope in when palliative care gets involved in those situations is to really allow the family to be listened to, so that they experience a voice. Most of the conflicts that I feel like I encounter are disparities in information, that judgments about values are being exerted by the clinicians before the information about what the values of the family and the loved one might be. And so that creates this antipathy or a feeling of mistrust. When they're getting disparate information, of course, it looks like nobody knows what they're doing. Or who am I supposed to believe? That's a problem. So, you know, when the first thing I do when I go into those family meetings is, you know, tell me some of the things that are worrying you right now. Or I'll ask, what have you been told? And then what are the things about that that worry you? And it'll come out. They'll say, well, this one said this, that one said that. I don't know what to believe. You know, what I heard was that, you know, they might get better. So, you know, and they said their blood pressure is getting better, even though, you know, they're on 5 depressors or something. You know, so I think it's just making sure that they feel like they're being listened to start, and then starting to work through, are we actually talking about the same information? And that's usually my sort of, I'm backing up, and it's usually just about, are we at information exchange right now? And is that all we have to focus on? Because their sense of the information is so messy, and our sense of the information may or may not be messy. You know, so we have to somehow get to, do we even see ourselves in the same place informationally, and then start talking about, so now what does this mean? So getting to what does this mean in those cases is hard, because then it can be 2 or 3 meetings before I can even get to that, you know, and they've already had those discussions, which makes it harder, because there's sometimes when I walk in the room and we start to talk, I tell them what palliative care is, they'll say, we're not taking them off the ventilator, before I say anything, you know, so clearly the goals have already been discussed, but whose goals is not clear, right? And so it's more just about, okay, let's just talk about, you know, what you've heard, you know, what is going on, what is, you know, how do you make sense out of that? What does this mean to you? You know, and then start to work back from that. Eventually, you know, that process helps them to sort of feel like they do actually understand everything. Every stone has actually been unturned. There is consistent information that they can now trust. It takes time to rebuild that, right? So that's what I got. So early involvement when it starts going sour, or when you think it's going to get sour. All right, thank you.
I think we're good. I don't see any questions from other sides. So thank you, everyone. Thank you so much.
You're welcome.